Assalamu alaikum and very good afternoon to everybody. Respected Chairperson, DG, Health Economics Unit, Ministry of Health and Family Welfare, respected sirs and madams, Institute of Health Economics, University of Dhaka, honorable guests from home and abroad, and distinguished participants. It's really great pleasure for me to say something regarding the role of Health Economics Unit in building the capacity in the area of health economics in Bangladesh. Actually, Health Economics Unit was established in 1994 as a project. And after that, HEU started its journey with the support of the then Overseas Development Administration, ODA, now Department for International Development, DFID of UK. It was aimed at developing an overall health economics capacity in the country so that it can facilitate to ensure delivery of cost-effective healthcare services efficiently through providing policy guidance to the government. However, to fill up the knowledge gap by the academicians, in 1998, ISU was established and HEU and ISU were in same OP. What is the present status of Health Economics Unit? Since 2011, it has been transferred to revenue budget. Now it is a full-fledged unit of the Ministry of Health and Family Welfare headed by one Director General. You might be confused. Actually, it was before Joint Chief. Recently, it has been upgraded or changed. We can say that the designation is now Director General. It is within the organogram of Ministry. Health Economics, Financing and JNSP is one of the 32 OPs of the Ministry. Two components, one Health Economics and B Gender, NGO and Stakeholders Participation. What we do? Actually, we provide policy advice to the government and we also provide training, that means capacity building, and we also conduct research and we arrange workshops to disseminate the research findings. And how we are doing? You see that we conduct research and we also arrange workshops, seminars to disseminate the research findings, and we also receive the important inputs from the relevant stakeholders. On the basis of the research findings and the inputs that we receive from the workshop, we prepare policy paper, policy input for the government. So far, HEU produced 32 policy briefs. Sometimes it also happens that HEU provides technical input as per requirements made by the ministry. For example, now we are working on resource allocation formula. It was the requisition from the ministry that HEU should provide technical inputs, and that we are working on that. How do you conduct research? HEU mainly conducts evidence-based research related to health economics and health financing issues. Research studies are conducted in-house and also commissioned to external research organization. Because our capacity is very limited, and we cannot conduct all the studies, especially the big study. For example, national health accounts. We have conducted 3 rounds of national health accounts and it was outsourced. So sometimes we commission to external research organizations, and mainly we had little involvement in conducting those type of researches. But now we are doing with the collaborative approach that we are trying to institutionalize this type of thing. For example, the national health accounts, and also through establishing BNSSL. Number of research papers and research notes so far prepared by Health Economics Unit are 49 and 21 accordingly. HEU has also another branch that deals gender, NGO, stakeholders and participation. If you see this slide, that research trend from 2007 to 2007-8 to 2011-12, we are considering the financial year, that in the year 2007-8 it was 2, we conducted 2 researches. 2008, 2009 it was 2, and the 2009-10 it was 3, and the lowest one was 2010-11, and the highest one was 2011-12. You see the highest. Why? Because it might be known to you that we are going to start pilot activities for SSK, Shastha Surakha Karmoshuchi. That's why we had to conduct a good number of studies before we are starting the pilot. How do we disseminate? We arrange seminars, workshops and conferences. We publish bulletins, establishing networks and preparing CDs. And I will try to focus on capacity building. Actually, Health Economics Unit provides training for the GOB officials on health economics and GNSP issues. And we call it PDT, that means Professionals Development Training. Every year, about 150 to 160 participants from different organizations, including Ministry of Health and Family Welfare, they receive training from Health Economics Unit. The trainings cover economic evaluation in healthcare, costing procedure, healthcare financing, research methodology, expenditure tracking, gender and equity issues, etc. If you see the trend of training that we will find here in this slide, the blue one is the local training and the red one is the foreign training. All the time you will see the blue one is always higher and it is cheaper. So, and some of the years we could not send the people in abroad. So, yes, for example, 2009-10 and 2010-11 we did not send people for foreign training. Constraints. This is a very important part. What we don't have, we don't know. And maybe this type of, though 2 decades have been passed, after these 2 decades, we are arranging this type of conference to trace our available resources, what we have. So, and again the next step would be, we don't have that type of mechanism which can develop to pull the resources. For example, after finishing of this symposium, then we would be able to trace the resources. But we need to know that mechanism, how can we pull those resources? And the next one, if we know that how should we develop, how should we use them, then we need again managerial capacity. But we don't have sufficient managerial capacity to utilize the available resources. So that is that part we should also address. And again, the last bullet, but very important bullet, that health economics might be still is an alien term. I intentionally use this term because we don't have the proper statistics. How many people, how many important people, rather I should say, have clear understanding of health economics, because they will take the policy decisions. And if they don't understand it clearly, that may matter a lot. So what is the way out? We need to explore the resource pooling options. And we need to establish, we need to strengthen networking, and we also need to build institutional memory. Why? Because many of the things are very technical, and the high turnover, especially in the public sector. So if we don't have the institutional memory, that may hamper all the activities. So we need to think about that, and we need to explore the opportunities and make them functional to the best use of the available resources. And again, capacity development is not for the year 2013, it is actually a continuous process. That we are arranging one workshop and we provided some trainings, and we don't have, we are not following up, and we don't have the feedback, so that will not bring any change, that I understand. And I have mentioned here that 3 strong C's. What are those? Coordination, communication and cooperation are needed. Actually, we strongly felt when we designed the healthcare financing strategy. Though we had not that much of resources, we had the limited capacity. Till then we could do work, and that was only through the coordination, communication and cooperation. And now we are working. Actually, there is another, there is separate session for that, so I will not discuss it more. Already my sir, Sushil Ranjan Haladar sir, he already mentioned that why we need health economics. So this slide also gives some that this type of message also, that health economics, the science of optimism. Health economics, it is the cheerful face of the dismal science. Two certainties in life, death and taxes. And I have borrowed this slide from the some important person. So health economics is concerned with carrying death with efficient health care. Actually, he mentioned here postponing death, but I slightly change here that carrying death. I don't believe that I can stop death or I can postpone death. That's why I used intentionally carrying death with efficient healthcare. And the second one is reducing taxes by using good measurement and management of costs and outcomes data. Health economics should be creative agents concerned with improving population health at least cost. And all these things, if we want to make it practical, we need more hands, more cooperation. And the last slide with thanks will give you that message. You will see many hands. If we join together, that can make difficult tasks easier. Thank you very much.